Chest pain is the second most common complaint in the emergency department, accounting for approximately 7 million visits per year in the United States. The diagnosis and triage of acute coronary syndrome is based on 4 distinct criteria. The first is a clinical assessment, which is derived from the symptoms at presentation, including the type and characteristics of chest pain, patient history, and vital signs. The second is the electrocardiogram, ECG. Cardiac troponin biomarker concentrations determined at presentation, followed by serial changes, constitute the third and fourth criteria. Together, these factors should be interpreted as quantitative variables and further integrated to allow for patient triage into low likelihood or high likelihood of an acute coronary event. Differentiating between myocardial infarction and myocardial injury is a key concept in the universal definition of MI. The term myocardial injury should be used when there is evidence of elevated troponin concentrations with at least one value greater than the 99th percentile upper reference limit. The term acute myocardial infarction should be used when there is acute myocardial injury with clinical evidence of acute myocardial ischemia, like symptoms, ECG, or imaging, with detection of a rise and/or fall of troponin. Similarly, at least one troponin concentration has to be above the 99th percentile. This figure illustrates the spectrum of myocardial injury, ranging from no injury in the white area outside of the circle to myocardial infarction in the center. Although elevated cardiac troponin values reflect injury to myocardial cells, they do not indicate the underlying pathophysiological mechanisms. However, regardless of the mechanism, acute myocardial injury, when associated with a rising and/or falling pattern of cardiac troponin values with at least one value above the 99th percentile upper reference limit and caused by myocardial ischemia, is designated as an acute myocardial infarction.